Osteoarthritis is a very common disease. On step 1, common diseases show up in questions really often. Sometimes they'll give you a presentation that'll make you think of another disease, but won't give you that single additional classic feature that gives you a more exotic diagnosis than OA. Remember, common diseases present uncommonly frequently, while uncommon diseases present commonly infrequently. Always remember to consider the simple, easy, common diagnosis first, and only go with something more exotic if in fact you're given a detail that makes you truly confirm it. Osteoarthritis is a disease that's thought to be mechanical in etiology, with chronic wear and tear of joints that leads to destruction of articular cartilage. It's often marked by nodules in the DIP and PIP joints, called Heberden's nodes and Bouchard's nodes respectively. It almost exclusively occurs in older individuals, especially those who are obese, which puts much more mechanical stress on the joints. Prior history of joint deformity also predisposes, for example, multiple prior joint injuries. Usually patients will present with osteoarthritis with pain in the weight-bearing joint after repeated use, particularly at the end of the day, which improves with rest. When it's in the knee, it's usually the medial aspect of the knee. There are a couple aspects of this disease that make it more classic. For one, this is a non-inflammatory arthritis. When we speak about the different inflammatory arthritides, this will be more clear, but because there's no chronic inflammatory undertone to this disease, there are no other systemic symptoms that come along with it. This is really different from chronic inflammatory arthritic diseases like rheumatoid arthritis. Knowing this with pathology, do you think we'd more commonly use steroids to treat osteoarthritis or rheumatoid arthritis? Right, they'd be more useful in rheumatoid arthritis, in which their anti-inflammatory properties would have a greater effect. You can use glucocorticoids, but much more commonly we just use NSAIDs for osteoarthritis. If you look at the image provided at the bottom of the fact, you'll see a number of classic patterns of simple osteoarthritis that will appear both pathologically and radiographically. On the left side you'll see the basic anatomy. There's a large joint capsule that travels up the side of the joint as well. Within that there's a synovium which provides further protection for the joint, and finally a piece of articular cartilage on each side of the joint, overlying both bones. The radiographic features of osteoarthritis might be worth committing to memory, not just for step 1 but for the wards as well. In osteoarthritis, the normal anatomy can be markedly affected. For one, the capsule can thicken and the synovium will hypertrophy. The joint space itself can narrow, with ulcerations developing in the articular cartilage surfaces. This can also lead to bone touching bone directly, leading to sclerosis and bone cyst formation. Finally, osteophytes may form, which can protrude into the joint space or out of the joint borders. With all of these pathological changes, it's not hard to believe that patients with osteoarthritis can experience significant pain from the disease, which might even require joint replacement. In contrast to a non-inflammatory disease like osteoarthritis, rheumatoid arthritis is the first of a few inflammatory arthritides that we'll discuss. Rheumatoid arthritis is thought to be an autoimmune arthritis affecting synovial joints with formation of a pannus in the joint. Pannus just basically means an overhanging flap of tissue, and is most commonly used to describe this in rheumatoid arthritis. Clinically, as with many autoimmune diseases, which gender do you think is more likely to experience rheumatoid arthritis? Exactly, women, often younger women. Also, as with most autoimmune diseases, it's important to know some of the key immunologic properties that distinguish this disease from other autoimmune diseases. For one, it's marked by type 3 hypersensitivity reaction, which you'll remember from the immuno lecture is antibody complex mediated. Classic antibody is called rheumatoid factor, appropriately, which is actually an antibody that develops against IgG, another antibody. However, only 80% of people with this disease actually are positive for rheumatoid factor, so while it's important to know, it's not necessary to make the diagnosis per se. There's another antibody called the anti-CCP antibody, or cyclic citrullonated products. These CCP molecules are thought to be involved in the inflammation that happens in the joint of people with rheumatoid arthritis. While the anti-CCP antibody is less common, thereby making it a less sensitive indicator, it's also more specific, meaning if it is positive, you're much more likely to truly have rheumatoid arthritis. Also, there's a segment of the HLA molecule, DR4, that is associated with rheumatoid arthritis. Classically, patients with rheumatoid arthritis present with morning stiffness, lasting longer than 30 minutes, which gradually improves with use. Patients with osteoarthritis will have morning stiffness as well, as a result of not moving all night while asleep, but this often resolves in less than 30 minutes. Also, the disease tends to be systemic, so if certain joints in the hand are affected, then the same joints of the opposite hand tend to be affected. Most importantly, though, you'll see systemic symptoms in patients with rheumatoid arthritis, a very important clinical indicator to help make the diagnosis. Systemic signs will include fevers, fatigue, and more subtle things like pleuritic chest pain, or vague chest pain signifying pericarditis. Just to double check, do you know what we mean when we say pleuritic chest pain? Pleuritic chest pain is pain that hurts when you take a breath. Anyway, use these differences to choose between the two options on step 1 questions. First-line treatment for rheumatoid arthritis involves use of NSAIDs to decrease inflammation. Selective COX-2 inhibitors, such as celecoxib, are also frequently prescribed, especially if the patient has a history of GI issues with NSAID use. Glucocorticoids and other drugs which modulate the immune response may also be taken by these patients. Clinically, the physical exam and radiographic findings can be very telling for rheumatoid arthritis. The physical exam may show subcutaneous nodules which would appear like small bumps, often not incredibly large, but usually multiple are apparent. These rheumatoid nodules don't only have to be in the skin, but can also be in the lungs or other viscera. Exams of the joints themselves should focus on the hands, particularly looking out for ulnar deviation and subluxation of finger joints. As you might imagine, chronic inflammation within the fingers will lead to many frank deformities of the joints. Within the fingers themselves, MCP and PIP joints are classically involved, but characteristically, the DIP joint is not involved. This is in contrast to osteoarthritis. Patients with autoimmune diseases will often have multiple autoimmune diseases at the same time, and one of the most classic pairings in patients with rheumatoid arthritis is Sjogren's syndrome. Classically, there's a triad of 3 symptoms that are seen. Xerophthalmia, which refers to dry eyes, might present with patients saying the sensation of sand in their eyes, namely because they're not producing tears effectively. Xerostomia, which means dry mouth, can also cause dysphagia, namely because chewed food is not being lubricated with enough saliva to make it easy to swallow. Number 3 is, of course, arthritis. As you probably guessed, xero comes from the Greek word for dry. Patients with Sjogren might also present with parotid enlargement, which occurs because it's only the submandibular and submaxillary salivary glands that stop producing saliva, while the parotids have to make up the difference, and they compensate by enlarging. These patients also have an increased risk of B-cell lymphomas, which are more likely in patients with autoimmune diseases as a result of chronic inflammation that predisposes to dysplastic changes. Finally, patients with Sjogren's are also more likely to have dental caries or cavities, likely because saliva has a number of chemicals that aid in dental health. The antibodies to know for Sjogren's disease are anti-RNP, anti-SSA, also known as Rho, and anti-SSB, also known as La. Rho and La are probably the more common ones to remember. Sjogren's tends to affect females between 40 and 60 years of age who often already have a history of rheumatoid arthritis. That being said, you don't have to have rheumatoid arthritis to get Sjogren's. In fact, a related syndrome, Sicca syndrome, presents with many of the same features, just without the arthritis. They'll have dry eyes and dry mouth, as well as dry nasal and vaginal cavities, as well as chronic bronchitis and reflux esophagitis. Most importantly, there's no arthritis. The next disease we'll discuss is gout, a pretty common disease that's important to know well. Biochemically, this disease is characterized by precipitation of monosodium urate crystals into joints due to high serum uric acid levels. There are a lot of causes of gout, theoretically due to 2 major problems. Uric acid can either be overproduced or underexcreted, which can cause high serum levels, thereby leading to a higher likelihood of crystal deposition. Of the two, 90% are caused by underexcretion. The causes include Lesch-Nyhan syndrome, PRPP excess, iatrogenic causes like medication, von Guericke's disease, or increased cell turnover. The case vignettes are always rather similar, usually with some external insult leading to a gout flare, likely in a single joint, most commonly the MTP joint in the toe. A classic example is a patient who is treated with chemotherapeutic drugs for leukemia, who turns over cells quickly due to rapid cell death from the chemo, leading to a huge overproduction of uric acid. This precipitates a gouty attack, thereby causing a man being treated with standard therapy for his cancer, presenting to your clinic with joint pain. The way oncologists have historically avoided the problem is by pre-medicating all patients with large tumor burdens with allopurinol, a blocker of uric acid production, to prevent it from being created and allowing serum levels to stay low. We'll discuss this a little more in the pharm section. The symptoms of gout classically consist of an asymmetric joint distribution and often a red, swollen, painful joint, most commonly, as we said, the MTP of the big toe. With long-standing gout, the crystals can precipitate in deposits. These are called tophi, tophus singular, which can be anywhere, but classically appear on the external ear, the olecranon bursa, and the Achilles tendon. If a patient has these long-standing signs, you should have a high suspicion for tophaceous gout. Remember, the tophi themselves don't cause the problems, it's the acute attacks that are painful, and they don't occur at the sites of the tophi necessarily. These attacks are often precipitated by eating a large meal, or by drinking alcohol, both of which allow for uric acid levels to increase. With alcoholism, as with HIV and certain other important chronic diseases, it's important to build a list of common complications and diseases that often present with them that you can use as a shortcut when you see them in a clinical vignette. This is a great one to add to the alcoholism folder in your brain, along with thiamine, B12 folate deficiency, and delirium tremens, which you'll remember from the biochem chapter. Do you remember the name of the disease seen in alcoholics caused by long-term B12 and folate deficiency? Right, Wernicke-Korsakoff syndrome. The treatment for the disease is varied and usually determined by the clinical presentation. In the acute period, a patient is coming in because they have a very painful joint. The goal here is not to try to acutely drop serum uric acid levels. The goal is simply to control pain and inflammation. This is accomplished best with good old-fashioned NSAID therapy, but you can also use steroids and sometimes colchicine. However, when the acute flare is resolved, the goal is to actually try to control serum uric acid levels and keep them low so patients are less predisposed to attacks. This is accomplished mainly by allopurinol, which inhibits the formation of uric acid, and less commonly by probenecid, which causes the kidney to excrete more uric acid. Before we move on to pseudo-gout, we should talk about one more aspect of making a diagnosis of gout that's important. To make a definitive diagnosis, often you look at the crystals that precipitate into the joint space. They're described as needle-shaped and negatively birefringent or yellow when parallel to polarized light. This comes up a lot in questions, so it's worth remembering, especially as it's the main way to distinguish between gout and pseudo-gout. Just remember that for gout, the words yellow and parallel both have double L's in them. Pseudo-gout's quite literally what it sounds like. It sounds just like gout, but it's different. The key distinction when you're trying to make the diagnosis is seen when you observe the crystals under microscopy. Rather than appearing as yellow when parallel to polarized light, like what happens in gout, in pseudo-gout they appear blue, and then yellow only when perpendicular to polarized light. The crystals are basophilic and rhomboid and are weakly positively birefringent. The reason for the different properties under polarized light is that the crystals in gout are made of monosodium urate, as we discussed, but in pseudo-gout they're made of calcium pyrophosphate. Just remember that P is for both pseudo-gout and pyrophosphate. Another major difference is the joints that are affected. Rather than the MTP joint, classically they feel pain in the knee or sometimes the shoulder. Patients are older and equally split between males and females, while gout tends to affect mainly males. Also, as opposed to gout, there isn't really a major treatment other than supportive care. Infectious arthritis is quite often an orthopedic emergency. Why? Because it's a raging infection that's restricted to a small space in the joint. Usually it presents in a single joint that may then move to another joint, often asymmetrically. It presents with three different possible problems: synovitis, often in the knee, tenosynovitis, often in the hand, and finally dermatitis. There are classic organisms that cause septic arthritis, most importantly Staph aureus, Streptococcus, and Neisseria gonorrhoeae. You often see a classic boards question of a young adult who's sexually active who has a history of STDs who presents with red, hot, raging joint pain, which often represents septic arthritis caused by Neisseria gonorrhoeae. When you see the teenager and joint pain in a question, your brain should automatically go to this. Here you can see typical skin lesions due to disseminated gonococcal infection. Osteonecrosis, or avascular necrosis, occurs when the blood supply to bone is interrupted. It often presents clinically as a pain that occurs with activity and can be caused by a variety of etiologies, including trauma, high-dose steroids, alcoholism, and sickle cell disease. If the blood supply to the part of a bone involving a joint is affected, it can often lead to destruction of the articular surface, causing significant joint pain. This often happens in the femoral head. On X-ray, it generally presents with irregular, non-uniform patterns of lucency and opacity in the affected region, with possible joint changes if the articular surface is affected. Seronegative spondyloarthropathies is a long term for a somewhat straightforward set of diseases. Basically, there are a group of 4 inflammatory arthritides that affect the spine and are seronegative. That is to say, they have negative serologies for rheumatoid factor. Commonly, these diseases affect males more often. Among the more boards relevant facts in this section is that these diseases are associated with HLA-B27, a gene that helps to encode for MHC1 molecules. Again, there are 4 types of seronegative spondyloarthropathies, including psoriatic arthritis, ankylosing spondylitis, inflammatory bowel disease, and reactive arthritis. A list you can remember with the memory aid pair. Psoriatic arthritis is exactly what it sounds like, an arthritis that's strongly related to psoriasis that presents often with joint pain and stiffness. Around 1 in 3 patients with psoriasis will develop the related arthritis. The reason to keep this disease in mind is that the clues on radiography are often giveaways. For example, you'll often see a pencil and cup deformity, as well as dactylitis, or sausage digits. These are some of the buzzword phrases that should immediately take your brain to this disease. Ankylosing spondylitis is probably the most classic of all the seronegative spondyloarthropathies. It's a disease characterized primarily by chronic inflammation in the spine, classically in the sacroiliac joints, and then ascending up through the spine. As it ascends, it causes fusion of the spine, eventually leading to a complete loss of mobility. This ankylosis can be so severe that it may lead to a classic radiologic appearance known as bamboo spine, quite literally because vertebral bodies appear to square off and stack perfectly on top of each other. Additional symptoms include uveitis and aortic regurgitation. 2 important symptoms to know, as they can be common and should not dissuade you from considering the diagnosis of ankylosing spondylitis. The next arthritis discussed here is the one associated with IBD. There's no single differentiating symptom that you need to be aware of here, but expect that sacroiliitis that occurs in patients with pre-existing IBD is because of this seronegative spondyloarthropathy. Do you remember the two types of IBD from the GI chapter? That's right, Crohn's disease and ulcerative colitis. The final type of arthritis here is reactive arthritis, which used to be called Reiter's syndrome. It's known for a very classic triad of conjunctivitis, urethritis, and arthritis, which can be remembered with the memory aid can't pee, can't see, can't climb a tree. It's a great way to remember all the fully testable concepts. To consider the diagnosis, the question stem should really offer you a recent history of either a GI or a chlamydia infection, as these infections are what precipitate eventual reactive arthritis.